Welcome everyone to Supporting Practices with Accreditation Basics. I'll be your facilitator today, Elisa. My name is Elisa. I would like to begin by acknowledging country. Northwest Melbourne Primary Healthcare Network would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Wurrung people, the Bunurong people and the Wathaurong people. We pay our respects to elders past, present and emerging, as well as pay our respects to Aboriginal and Torres Strait Islander people in the session with us today. Just a couple of housekeeping. All attendees are muted. Please ask questions via the Q&A box only, and I will answer these throughout the session, and Rika will answer these for you. The session is being recorded as well. Please ensure that you have joined the session using the same name as your event registration or the phone number if you've dialed in. Northwest Melbourne PHN uses Zoom participants list to mark attendance, and certificates and CPD will not be issued if we cannot confirm your attendance. If you're not sure if your name matches, please send a chat message to Northwest Melbourne PHN Education to identify yourself. I'm just introducing our speaker today, who is Rika Hagen from Medical Business Services. Starting her professional career as a medical scientist, Rika successfully implemented and managed a regional laboratory of a major pathology provider before embarking on a career of medical practice management and general practice accreditation. She has a small, medium and large medical centres and has a strong interest in quality improvement, governance, business planning and financial management. Rika is a Director of Medical Business Services, providing consulting, advisory, coaching, training and mentoring services to health sector Australia-wide, including general practices. You may also know her as the founder and administrator of a highly active, influential Facebook group, Practice Managers Network, which now has a global membership of over 12,500 people.
Thank you so much, Elisa. Thanks everyone for coming to join me today for a bit of a natter about the foundations of RACGP accreditation for your practices. I would also like to acknowledge the traditional custodians of the lands on which we are meeting, and I am speaking to you from Dja Dja Wurrung country in the Macedon Ranges, so not too far away from where all of you are located. Now, today's session has a fair whack of content through it. So I just want to make sure that everybody understands that we cannot possibly cover all of the standards, all of the criteria, all of the indicators that underpin the accreditation framework, but we're going to look at a few select ones to help you get your head around the items that kind of cause a little bit of problems, I guess, or confusion for practices. As Elisa indicated before, I would love for your questions to come into the Q&A box as I'm chattering through. Elisa will bring them to me as we're going. So if you've got a question, then I would love to address it as we're chatting through. I really don't mind those interruptions. In fact, they kind of make the session a little bit more dynamic. Even if you've got some thoughts or some comments that you would like to bring forward, we would just really love to hear them. So don't be shy. You won't be asked to turn on your camera this time and actually speak. So pop your comments, your questions into the Q&A box, and we'll see what we can bring to light there. So for today, we're going to start off by looking at a little bit of the generalities of RACGP accreditation. We're going to look at the structure of the standards and how your practice can demonstrate compliance across the board. We're then going to start taking a little bit more of a deep dive into the three modules that underpin the RACGP standards. And the first one is around the core module. And in that one, we're going to have a look at the rights and needs of patients, ethical dilemmas, practice governance, and the like, risk management, contingencies, and safety. So some beefy topics there. Next, we're going to have a bit of a deep dive into the quality improvement module by specifically looking at what clinical quality improvement is all about. and patient feedback as well. And then lastly, we will look at the structure of the general practice module, and we're going to hone in on, it's actually not vaccine potency this time. We're going to be looking at infection prevention and control. So scrub that one out. We're going to talk a little bit about infection management within your practice. Okay, so let's start with the basics. We want to ensure that our practices are first and foremost eligible to be accredited to the RACGP standards. And in order for that to happen, practices or health services need to operate within the model of general practice that's been defined by the RACGP definition of what a general practice actually is. And that was updated earlier in this year, in 2024. So in essence, what the practice needs to be is a service that is predominantly of a general practice nature, but it can now have a broader focus too. So in the past, it wasn't possible to have, special interest types of general practice services be able to be accredited and therefore be able to tap into programs like the practice incentives programs and get some of that remuneration and reward for meeting quality standards there. But that's been broadened out, which is a really good thing, which means that, practices just have a lot more flexibility about who they are and how they are, and still be deemed to be a general practice, but you still need to be predominantly of a general practice nature. And what that means too is that the practice or the health service needs to be capable of meeting all of the mandatory indicators in the standards. So that's kind of the underlying principle there, that if you read through the RACGP standards, and if you kind of go, yep, we with effort, we can meet all of these standards, then it's very likely that your practice meets that definition of what a general practice is for the purposes of accreditation. And it definitely now includes residential aged care facilities, outreach services, and disability home services as well, and a few other sort of niche markets as well. So that's about the eligibility to even begin considering RACGP accreditation. So the cycle of accreditation looks something like this. It sort of starts with the notion that we are dealing with a cycle of continuous improvement. The RACGP standards exist so that our services have a higher likelihood of being able to provide safe and effective care to patients. That's the absolute foundational principle of why you or your practice would choose to undertake accreditation. So it's around that notion of continuously improving, testing what we're doing, and making tweaks along the way to get us better and better. So the cycle actually starts then with a self-assessment. So every 3 years, the practice will get the tap on the door, I guess, where the self-assessment kicks off. Your practice is due for accreditation. The self-assessment is usually undertaken within practices about a year out from the expiry date of your current accreditation cycle. And of course, if you're a new practice, if you've never undergone RACGP accreditation before, from the moment of registering for accreditation, you've got a year to be accredited. So that would be absolutely the time to start your self-assessment and audit process as well. Once you've undertaken that, and from your own perspective, you feel like you have met all of the mandatory requirements, then it is ready for the survey team to come into your practice. The survey team most often consists of a general practitioner, a GP, and usually a practice manager, or sometimes a nurse or another sort of relevant peer assessor. So there's always 2 people who will come to your practice to do that assessment. The workload is kind of broken out between the GP and the non-GP assessor. And they will usually spend about half a day at your practice to verify your self-assessment. So they'll be looking at all of your systems, your policies, your processes, and then come away with a viewpoint of where you have met or perhaps not quite met the mandatory requirements. Then mostly practices will have a couple of areas where they are deemed to have not been quite compliant to the degree that the assessors deem to be necessary. And practices are then given a period of time to provide some additional evidence to show that they in fact do meet the standards. It's usually, some additional policies, procedures, records that need to be evidenced before the determination is made that the practice has been, fully compliant, and therefore you then kind of go into that next sort of 3-year cycle. Once everything is kind of ticked off, you will get your accreditation certificate. You will need to upload that to PRODA, because that will be linked to your practice incentives program payments as well. And from this month, there will be now a new numbering system that is attached to those accreditation certificates. Very important that you realise and understand that that certificate number is a very important piece of work and information piece that help to tie together the completion of accreditation and the continuation of your practice incentive program payments. So that's a little bit about the cycle of accreditation. At this point in time, there are 4 major accrediting agencies. Probably the biggest one out of that is AGPAL, and then secondly, QPA, Quality Practice Accreditation. To a lesser extent, there are a couple of other accrediting agencies that assess to exactly the same standards. So the other 2 are Global Mark and the Australian Council on Healthcare Standards. So important to understand that if you get either AGPAL coming into your practice to do your practice assessment, or you get QPA or any of the other assessing organisations, the standards that they're assessing to is the RACGP standards. So it's not the AGPAL standards, it's not the QPA standards, it's the Royal Australian College of General Practitioners, the RACGP standards. There's often a little bit of confusion about that. What you might want to consider if you haven't chosen your accrediting agency just yet is perhaps taking contact with a couple of them, get some price comparisons, and very importantly to check in with them to see what support they can offer your practice as you are getting ready for your accreditation survey. And some organisations will do that better than others. And I think that's an important consideration, especially for newer practice managers. If you are feeling a little bit uncertain about this at all, then getting additional help in terms of access to resources, templates, guides, further explainers is a really solid way whereby practice managers and practice teams can become a little bit more skilled and confident about the process of accreditation. So like I said before, the surveying team consists of at least 2 surveyors, a qualified GP, and then a non-GP assessor, who will then get together, report on their findings. Once the visit on the day is done, the 2 surveyors will get together and kind of have a little bit of a debrief, first of all, with each other to compare their findings and come to some conclusions about where they feel your practice has done really well, and perhaps some areas where some additional information is going to be required. And on the day, there will be a debrief session, I guess, as well at the end of that survey visit, whereby the surveys will outline what you've done really well and where some additional information is likely to be required. Now, it's not the definitive end, but you can rely reasonably closely on what your surveyors will tell you. Sometimes what we find is what happens is that, when surveyors have gotten together and have presented a practice with some areas where they think the compliance isn't quite there yet, is that they just haven't seen some of the documentation or systems that point to your compliance there. So if you hear your surveyor say anything, you think, I think we're actually doing okay in that way, you can put your hand up and say, hang on, I think we're okay with that. Let us get some additional documentation out to show you what we are doing there. If that's the case, then the surveyors, will have a look at that. And if they think that that's okay, they will correct that on the day and go, rightio, we had missed that in our surveying process. But, most likely there might be some small gaps that you will still need to fill after the day is done. You will then get that period of time to prepare that additional material, which you will then forward onto your accrediting body in order to come to the assessment of you having met the standards in full. Another really important, component to remember about all of this is that accreditation is not a pass or fail type of scenario. So it's not an exam like you might get at school or at a university. There is a process of meeting your compliance rather than a pass-fail. So I'd really encourage everyone to try not to lose sleep over your survey visit. I know there is a lot of stress that's involved with the day that the surveys actually come, but I'd really encourage you, after all the hard work that you will have done to get ready for the survey assessment, that you kind of get the opportunity to showcase all the great stuff that you have been able to put together and celebrate that with the team. And whatever still needs doing after that, well, you can address that after the day. Now, sometimes too, there is disagreement between practices and their accrediting bodies about compliance. And there is an element of natural justice that underpins this entire accreditation process. So if you feel that, your assessors have not come to the right conclusion or have not interpreted your information accurately, then you have absolutely every right to challenge that and to bring that to attention to, come to a resolution there. So don't feel that the judgment has no sort of entering into by the practice. If you feel it's not fair, it's not just, then you've got absolutely avenues to address that as well. So the standards that we are referring to here are the 5th edition standards for general practices. There's a little image there on the screen that shows what the book looks like. It used to often be printed out as a book. I've still certainly got a hard copy, but you will find that all of the standards are now very easily accessible online from the RACGP website at no charge. So they're very easy to find. If you just do a Google on RACGP Standards for General Practices, it will all be there, and you can see every single criterion, indicator and standard that we're going to be talking about, and all of the other ones that we won't get a chance to talk about. There are a number of other documents that underpin the standards for general practices, though, and one of them is the RACGP Infection Prevention and Control Standards, which also happen to be the 5th edition. And there are a number of other guides and resources that are associated with that as well. There are computers and security guidelines. There are privacy guidelines as well, and requirements. So there's a big suite of resources apart from the core standards. There is a QR code on your screen there, but you will get access to all of the links and the resources that I'm talking about today at the end of today's session. I also want to draw your attention to the fact that as time goes by, the core elements of the standards are around for quite a long period of time, but the RACGP does introduce subtle changes periodically, and that tends to be on an annual basis. And you will find in the resources that you get, there are links to the updates to the RACGP standards over time. Now, this is important, especially if you print out the standards and you work from paper-based standards. If you use mostly the online version, you don't need to worry so much because those indicators and standards are kept up to date as they go along. So I probably recommend you lean more so on the online resources than any paper-based ones. So the structure of the standards then is essentially in 3 modules: the core module, the quality improvement module, and the general practice module. And we're going to sort of dive into each one of them. In terms of the structure of the standards criteria and indicators, it kind of looks a little bit like this. So the standards are numbered separately in each of the modules. So for example, we know there's 3 modules: the core, quality improvement, and general practice module. In the core module, there are 8 standards. In the quality improvement module, there are 3 standards. And in the general practice module, there are 6 standards. Then underneath each of those standards, we have criteria. And the criteria are numbered under each standard as well. And then underpinning the criteria are indicators, and the indicators are letters, A, B, C, D, and so forth. And each of those indicators are flagged as being either mandatory or not mandatory, in which case we kind of refer to them as aspirational. So let me give you a quick example of that. If we consider the core module, so that 1/3 of the pie slice, in standard 1, standard 1 basically says communication and patient participation. It's a chapter heading. That's what the standard is. Standard 1, communication and patient participation, tells you nothing about what's actually required in that. So we need to drill down further into that to get a better understanding of that. So underneath standard 1 sits a number of criteria, and one example is criterion C, standing for core module 1, referring to standard number 1, and point 1 relating to this criteria, which is about information about your practice as it relates to the standard communication and patient participation. Again, we now have a little bit more of an idea of what we're talking about, but still no detail. And for that, we need to drill into the indicator. So we can see now we are down to indicator A of core standard 1, criterion 1.1. And there we have a much more detailed statement about what is required. You'll see there's a little blue flag next to it, which indicates that it is a mandatory indicator, and it states our patients can access up-to-date information about the practice. So that is what the practice is being assessed to. It is the indicators assessment which forms the basis of your accreditation survey process. Underneath each of the indicators, there is a lot more information that explains exactly what that indicator means. And it is also underpinned by statements such as must, meaning you have to have several elements in order to show compliance to that indicator, or you could, giving you some more ideas about the ways that you could go about demonstrating your compliance. So what does compliance look like? Well, first and foremost, we are dealing with an outcomes-focused process. So the standards are very much interested in what the patient receives rather than what the practice delivers. So the standards are viewed from the perspective of the patient and patient-centeredness, and how the practice goes about delivering that outcome for patients. That's of far more importance than the actual methodology in many instances. So that outcomes focused is informed by a number of ways of showing that compliance. Mostly that's around interviews, so there'll be chit chat, right? The surveyors are going to be talking to the GPs within your practice. They're going to be talking to the practice manager, they're going to be talking to your nursing staff, and they will very likely also speak with your reception team as well. So that's interviews. We're wanting to hear from the team on the ground. What's your understanding of how do you go about, what are the systems in place, etc. That's going to be aligned with document reviews. So that's your policies, your procedures, and your records. So they're going to be looking for congruency between what you say you do and what you have written that you do. So what's your operating environment? And then that's also going to be observed. So there'll be direct observation of what's in the practice, what's around the practice. Is it safe? Is it congruent? Does the whole picture kind of add together? So interviews, documentation, and observation are the three key methods by which compliance can be demonstrated. So the intent of the standard must be met. So this is kind of both good and bad. The intent of the standard tells us that we need to understand the underlying importance of why an indicator, a criterion, a standard is important. And so the intent means that practices have different ways of showing compliance, and that's very much aligned with what your practice is, how big it is, how many practitioners you've got, and what your operating environment kind of looks like. So what that means too is that the surveyors are going to have perhaps a different standard of performance for larger practices than what they necessarily might have for very small practices. So you can imagine that for very large practices where there is far more resourcing available, that the expectation to have more solid documentation, more detailed governance processes in place compared to, say, a solo or very small GP practice. So it's kind of like putting the lens of what is this practice? What is fair, reasonable, and does the compliance indicators indicate that this practice has met the intent of the standards, and is it adequate for this particular organization? And so it introduces that flexibility of how you go about it. What works for your practice? What makes sense? One really, I guess, clean example of how that might apply is in the process of business planning. We'll talk a little bit more about that in a moment. But, business planning can be like really modest action planning, maybe your PDSA plans that you submit through the PHN as part of your QRPIP process. It could be as simple as that. Or for larger organizations, it could look at a full suite of strategic planning, business planning, operational planning, many levels of that planning and business envisioning, I guess, that you could do. One will be very appropriate for larger practices, but that would not be a reasonable requirement to have of really small solo teams that simply wouldn't have the resourcing to be able to support that. So think about what would be fair and reasonable for your practice. There is also an RACGP resource guide. Again, you'll get the link to that as well, which will give you more information about developing your systems and your processes, further documents and resources. Together, resources from your accreditation provider. It will help you to get started. So you put all of those bits together. A lot of reading involved, especially for the practice managers who are a little bit, I guess, in their earlier stages of their practice management career. You will need to do a lot of reading. There's a lot to get your head around, and you've got to give yourself enough time to get across the scope of what's going to be required of you. But it's all there, right? You don't need to dream anything up. It's all already there for you to tap into and apply it to your practice efficiently and effectively. So, okay, so let's have a look a little bit more on this notion of what does an outcome focus kind of really look like. I hinted at it before. So we're talking about patient-centered outcomes. That means that there is the ability to make choices based on informed decisions. So this is for patients. That patient engagement and empowerment in healthcare is really critical in this space. We need to give voice to patients and how they receive their care. The focus is on what the patient receives rather than what the practice does. And it includes educating the patient and informing them of what they might encounter when they access your health services. So here is an example of the difference between what a process-focused indicator looks like compared to an outcome-focused indicator. So the process-focused indicator might say something like, our practice has a documented system to identify, follow up, and recall patients with clinically significant results. And that was the wording that was appropriate in previous iterations of the RACGP standards. So the focus was on the documentation of the system and the process. This is now flipped around to an outcome focus. And what that then looks like is that our practice recalls patients who have clinically significant results. Far less focus on the process, but entirely focus on the outcomes. We want to ensure that patients with important results are recalled and that they receive them. Flexibility on the how. Let us work with what our team looks like and what our service looks like to ensure that we land on success with getting that patient back in to receive their results. In the previous iteration, we might have had a documented system, but if that wasn't implemented or implemented well, then we're still not getting the outcomes. So that's the shift that's happened over time. Okay, we are now going to pivot into the 3 modules, and we're going to start off with the core module. As I said before, there are 8 standards in the core module. Standard 1 is around communication and patient participation. Standard 2 is around the rights and needs of patients. 3 is practice governance and management. 4 is health promotion and preventive activities. 5 is clinical management of health issues. 6 is information management. 7 is the content of patient health records. And 8 is the training and education of non-clinical staff. And we're going to focus just on 3 standards where you can see the little green stars next to them. So we're going to have a closer look at standards 2, 3, and 6. I'm just going to pause there for a moment and just check in with Elisa to see if perhaps any questions have come up whilst I've been nattering along.
Hey, no questions have come up my way, but if anyone does have anything, please pop it in the chat and I can interrupt Rika as she goes along.
You guys have been very quiet, so come chat with me, and for sure pop your questions in there. That would be really terrific. All right, so let's have a look then at core standard 2 around the rights and needs of patients. So standard 2, remember this is the chapter heading, states that our practice respects the rights and needs of patients. That's pretty obvious. And the RACGP General Practice Patient Charter is aligned with the ACSQHC's Australian Charter of Healthcare Rights, and that's a very big acronym there around the Australian Council for Safety and Quality in Healthcare. So very big mouthful there, but there are charters around that of what patients might be expecting to receive and what they have a right to receive. It also describes some of the responsibilities that patients have in that journey of accessing your care as well. And be aware that there are some specific charters that are appropriate for Aboriginal and Torres Strait Islander people as well. So in this particular standard, we are looking at indicator C2.1E. It's got a little red flag there. So this is mandatory around ethical dilemmas. And I've kind of picked this one out because it causes a little bit of confusion for many practice managers and certainly the newer ones as well. So ethical dilemmas, they state, you must have a document of ethical dilemmas that have been considered and the outcome or solution have been identified. So many practices kind of struggle with going, well, what even is an ethical dilemma? And how do we go about like documenting that and providing the evidence that we meet this indicator around identifying ethical dilemmas? So in the top right-hand corner, I've identified a couple of examples that might be helpful to get you going. So one might be around practice staff attending the practice as patients as well. That's a bit of an ethical dilemma because of the conflict between being a staff member and being a patient, respecting your privacy, and whether it is desirable for the doctors, who might often be your bosses as well, to have that sort of oversight and input into your own healthcare. So that feels a little bit conflicted, doesn't it? And in many situations it is, but in some situations it is unavoidable. So for example, in metropolitan practices, many will kind of go, well, look, this is an ethical dilemma. We're going to make some determinations that if you are a member of staff, you are required to receive your care from a practice other than the one that you work at. So that's one way of resolving that ethical dilemma. But for other practices, for example, those based in like remote areas, they might be the only practice in town, and it may not be feasible for that to happen. So that ethical dilemma might be, we need to understand that we still need to provide care to the community, and that community happens to also include our staff. And we may then lean into additional safeguards to say, how do we manage this ethical dilemma so that we protect patient privacy, staff privacy, and how do we work that through? So that's one example of an ethical dilemma. Another one might be around gift giving. Do we accept a bottle of wine at Christmas time? For some practices, the answer would be, well, yeah, why wouldn't you? We're pretty okay with that. It seems, pretty lowbrow. Other practices might say, well, we have an objection to alcohol, so we will not accept wine at Christmas time. Or it might look something different. So I'm just giving you just some examples. The important thing here is that this indicator does not give you any sense of right or wrong as to where you land. It's asking you to contemplate it and what makes sense for your practice. So there is no right or wrong leaning on any of these ethical dilemmas. There is just consideration of them within the practice team. So you've got to consider them. So how would you practically do that? You first of all will want to start with a bit of a policy and procedure that explains how your practice manages ethical dilemmas, i.e., we invite the team to first of all identify them, right? If we don't know that we've got an ethical dilemma, then kind of nothing happens after that. So how do we do that? Do we bring it to a team meeting regularly whereby we say, have there been any ethical dilemmas that have been identified over the last, month or quarter or whatever it might be? And, the more that you weave that into your general way of being, the more skilled your staff will become to recognize when things become a little bit conflicted. And then they might go, oh, I've identified something and I think we need to have a talk about that. So pop it onto your team meetings or your huddle chats if you have those instead. Yes,
we just had a quick question.
Yes.
The question is, it says to keep it says to keep separate from the clinical file. Can this be documented in a soft copy format, not on physical paper, but on our internal Google Drive?
Oh, absolutely. Look, yes, absolutely. So if there are sort of any ethical dilemmas that impact on patient care, then that the dilemma itself does not form part of the patient's health record. So I guess a good example of that is the third example that I haven't spoken through in terms of the provision or denial of specific services. So, for example, you wouldn't document in a patient's health record that Dr. X is not prepared to deliver service Y, and why that might be. That's not an appropriate capture within a patient health record, but you would keep that separately as a policy or as a procedure, and you would need to then determine, how do patients become aware of that? How do we make that known in a way that's acceptable to the patient? How do we, as an organisation, work around the dilemma that it causes? So that's the, I guess that's the instruction in terms of keeping the ethical dilemma separate from a clinical file. Has that explained it cleanly enough for you, Elisa?
Yes, I believe so. Please reply to my message if it hasn't, and I'll let Rika know.
Yeah, excellent. Thank you. That's great. All right, so let's now have a look at core standard 3 around practice governance and management. We're just going to do a little bit of a skirt over this. We could do a whole session just on this particular standard and criteria and indicators. So there's a fair bit that sits behind that. So criterion C3.1 is around business operation systems. And for the 3 that you see identified there with the flag next to it, you must have those in place. And there is one criterion that is still mandatory at this point. So indicator A states that our practice plans and sets goals aimed at improving our services. And so that kind of speaks to that notion of business planning and proactive, I guess, foresight and goal setting. So it could be a PDSA, it could be an operational plan, you could call it a business plan, you could call it a strategic plan, you could call it an action plan. It doesn't really matter what you call it, but it needs to be, again, appropriate for the size and scale of your operation. And it kind of needs to make sense in terms of who you are and what you deliver, that what your plan sets forward kind of makes sense. Now, there are a number of, I guess, templates that are available to help you kind of get going on the thinking about what you might put into your action plans or your business plans. And the focus as far as the RACGP is concerned should be very much on the clinical service provision and how you might improve those services. So that's what the assessment is most interested in. I guess I would argue that you'd want to be broader about that and certainly look at your business viability and revenue and staffing and all of that. You definitely want to do that. Some practices feel a little bit more coy in that they might have some plans that include, quite private, business confidential information. Feel free to withhold that. You don't necessarily need to share all of your business planning with the surveyors. That's perfectly fine. If you focus on the clinical service improvement, then you're going to go a long way towards meeting this requirement. Indicator B kind of follows on from that, where it says that you evaluate your progress towards achieving those goals. And again, for me, that's a bit of a no-brainer, right? What's the point of setting a goal if you're not going to check in from time to time to see, are you getting there? What have you done? Where have the wheels fallen off? And how are you tracking with that? So I think indicator B, even though it's not mandatory, so if you're not doing that evaluation piece just yet, it's not going to impact your accreditation status. But if you're not doing that, then I think you're only doing half a job. And I would also say that further iterations of the RACGP standards will make this mandatory over time. So I'd still be looking at doing that. Indicator C is around risk management. So you need to have a way of identifying, monitoring, and mitigating risks in the practice. Again, the risks are broad and wide, but the ones that the RACGP is most interested in is the ones that are going to impact on your patient well-being. So think about your clinical risks, the mistakes that might happen, missed results, all of that sort of a thing should go into a risk matrix whereby you look really closely at how your practice safeguards against these things going wrong, which will have a critical impact possibly on patient health outcomes. If all of that sounds a little bit overwhelming and you're going, oh my gosh, where do I get such a register going or whatever? Again, at the end with the resources that you will have access to, there's some information to get you going and to help you along with that risk management if that's troubling you as well. And then finally, the practice needs to have a complaints resolution process in place. and that will require a policy, a procedure, and evidence that your practice is managing risks, I beg your pardon, complaints adequately. So there's a fair bit more that sits underneath those explanatory notes of each of those indicators there. Okay, so coming back to risk management, just an idea of some of the really common areas of high risk for practices. Record keeping, so this is health records and communication with patients. Near misses, mistakes, and adverse events, and that overlaps with some standards and indicators in the quality improvement module that we will talk about a bit later. Clinical risks, financial risks, computer systems, ICT, cybersecurity is a really, really big one at the moment, and that's not going to go away in a hurry. Privacy risks, making sure that you've got really good, robust privacy systems and processes in place. Patient consent, workforce planning, and Medicare changes. Again, the workforce planning, Medicare changes, etc., and certainly the financial risks are not really the ones that the RACGP is interested in so much. But as a practice manager, they're the ones that I'd be focused on absolutely, together with everything else that the RACGP standards really does look at. So again, minimising those risks is going to be very helpful in ensuring patients receive safe and effective healthcare, and that your business will keep ticking along in a successful way. Furthermore, in Standard 3 as well, in terms of governance and management, indicator C3.3A in relation to emergency response planning, you are required to have an emergency response plan in place for unexpected events like natural disasters, pandemic, unplanned absences of clinical team members. Now, I know in times gone past, PHNs did support the RACGP emergency response planning tool. I don't believe that that's happening anymore, and you can kind of nod or shake. Is that yes, or is it not happening anymore? Yeah, actually, come and join the conversation.
Not happening anymore.
Not happening anymore, which is a little bit sad. However, the tool is still there, and I would highly recommend practices to just pay some money and invest in that emergency response planning tool. It's an online tool. You'll get a login, you'll get your own credentials, and it will guide you to really effective emergency response planning. So follow the steps along the way. You will need to take some time because there's a fair bit of detail in there, but that can then constitute your emergency response plan. Again, the standards don't mandate that particular tool. So you don't have to use the RACGP emergency response planning tool. You can use another way of managing this if you so wish, but it does need to meet the intent of the standard and the requirements. You know, you will need to ensure that you've got adequate documentation to prove that. There are also some indicators around work health and safety, and it's not just RACGP, right? There are legal requirements that sit around that as well. As a business, there is a whole sort of legal compliance framework that sits right alongside the RACGP standards. So work health and safety is governed, you know, by different states in slightly different ways, but there's a big piece around worker health and safety, well worth your time to become really familiar with the Victorian requirements. Indicator A, our practice supports the safety, health and well-being of the practice team. And indicator B, the practice team is encouraged to obtain immunisations recommended by the current edition of the Australian Immunisation Handbook based on their duties and immunisation status. So that's, you know, sort of, you know, reasonably self-explanatory of what some of those requirements are there. As far as staff immunisation is concerned, first of all, you do need to get informed consent from your staff around disclosure of immunisation information, and of course the provision of any workplace related immunisation that might be recommended. So we want to try to ensure that we have a good understanding of what the immunisation status is of our staff, because we want to ensure that we help to keep them safe as we, I guess, provide our services to the community. So immunity to vaccine preventable diseases or immunisation status of the practice team members is known. That's an interesting, I guess, indicator too, because there are a couple of little shifts happening there as well, and you will want to keep an eye on what's happening with the intersection of the privacy regulations as well. And I'm hearing a little bit of chit chat that health organisations are moving away from keeping records on staff immunisation status because of the nature of, privacy and the risk of disclosures and breaches that might come along with holding that information. So I'm thinking that that could well be another ethical dilemma that comes along the way. Do we collect this information, or do we lean more towards, supporting beefed up privacy security measures there? So I'll let you have a bit of a think about how that might apply to your practice. But we do want to ensure that we do offer recommended immunisations that are appropriate to the duties to our various staff members. And you've got to think about all your team members, not just your employees. So that would also include your GPs, who are likely to be independent contractors or, tenant GPs. And there could be others that intersect with your team that work very closely with you. So it might be allied health professionals that kind of come and go as well. To what extent do we want to ensure that, we've got them covered as well? So you need to consider your needs there. As far as the recommended immunisations are concerned, it is in accordance with the NHMRC guidelines, which is in the immunisation handbook. And all healthcare workers that are directly involved in patient care or handling tissue should receive the immunisations that are listed on this slide here. I won't go through all of those, but you can read that yourself. And you also will want to think of specific risks that may warrant other vaccinations. So on top of that, there could be individual circumstances where additional vaccinations may be a really good idea. And again, the immunisation handbook will guide you through all of that. We're now moving on to Core Standard 6 around information management, and I'm just being mindful that we run out of time really quickly. There's just so much to cover. Indicator 6.3a around confidentiality and privacy of health and other information. So that's the criterion. We need to ensure that patients are informed of how our practice manages confidentiality and their personal health information. It kind of comes back to what I was saying before about, holding immunisation data on your staff. But this one, sort of specifically relates to patients and how we manage there. So you must collect personal health information and safeguard its confidentiality and privacy in accordance with a number of legislative requirements there, and they are listed there. The Australian Privacy Principles, which are contained in the Privacy Act 1988, the requirements of the Office of the Australian Information Commissioner. They have some really fantastic resources there as well. And health organisations have very specific requirements around that. So definitely worthwhile to really look up those resources and train yourself up. And I'm very much speaking to the practice managers there to understand your privacy obligations. Again, it's much broader than the RACGP standards, but there is alignment. So it's a legal requirement, not just an accreditation one. Long-standing legal and ethical confidentiality obligations, and then any other relevant state or territory laws that apply to that as well. So that's fairly beefy in there. All right, let's move on to the quality improvement module. We've just had a big talk about the core module. We are now moving on to that QI module. It has 3 standards. The first one is it's called quality improvement. The second one is around clinical indicators. And the third one is clinical risk management. So very specific focus on clinical risk there. So let's have a look at one of the criterion and indicators there around improving clinical care. So indicator QI, so QI module 1.3a, our practice team uses a nationally recognized medical vocabulary for clinical coding. And it lists there a number of different, I guess, languages that different software will use to provide clinical coding. So if you think about your best practice or your medical director, you will know that it has clinical coding capability whereby we tag each and every consultation with the core reason for the visit and the clinical coding, the condition coding that underpins that patient's experience. Now, this is, it hasn't got a flag on there. So this one is still mandatory at this stage as far as the RACGP standards are concerned. However, this is a mandatory requirement if you are tapping into the eHealth incentive of the practice incentives payment. So the practice incentives program payment, you actually have to do clinical coding. So not mandatory for accreditation, but certainly mandatory for the monetary reward to come through. The type of language, whether it is ICPC or 2+ or any of the others, will depend a little bit on your software. You don't need to fuss too much about which one are you using. It is pretty much baked into the software that you use. You know, you will want to ensure that the capability is actually implemented within your practice as well. So from an audit point of view, you will want to make sure that your GPs and your nurses are using that clinical coding to its full potential. So there is a bit of audit involved in that. That could become then a quality improvement activity in itself to say we can do better on our coding because coding is so important for us to hold accurate data on a population basis, you know, for our practice. This is why this is really important. So one way that you know, could be affected, or there's a couple of examples there. So you could use your practice management software to code patient health information. I think that's a really good idea for you to do that. You could also keep clinical data and reports, for example, on childhood vaccinations, completed health assessments and the like, and updating of patient health risk factors as well. So all of those activities kind of sit within that space. And another example might be just the maintenance of your registers that come through data extraction software such as Pencat. I don't think the Northwest Melbourne PHN uses Polar at all, but other tools such as Cubico could really come in handy there as well. So those are all the different ways in which you know, you could show your compliance there. And our practice uses relevant patient and practice data to improve clinical practice. So for example, chronic disease management and preventative health. So it's one thing to be able to access that data. It's another thing to actually use that data for quality improvement activities. And that's the bit that is flagged, right? You have to do that. So important for you to get your head around all of those requirements. On patient feedback, there's a bit to say about that. There are a number of, I guess, commercial products that are available. You need to, once every 3 years, undertake what they call validated patient feedback through one mechanism or another. The options there are, you could develop your own questionnaires, and there are some guides available, again, through the resources that you'll get access to. You will be given a full sort of document to guide you through how you could develop your own questionnaires. You could run focus groups and patient interviews. Not too many practices do that because there's a bit of time impact involved in that. And most practice managers don't really have the time to do that. And what you're going to get out of that is likely a much smaller sample size of feedback to rely on compared to doing broader surveys across many more patients. You can also consider doing ongoing, continuous patient feedback surveys. I love that idea because I think we always want to have our finger on the pulse of what our patients are thinking of our services, the suggestions that they have. I love, the idea of online forms via QR codes available at the front desk of reception for patients to quickly be able to zap that QR code, and just a simple, feedback mechanism to let you know how you're tracking and how you're doing. You would do that in addition to the once every 3-year validated patient feedback. Once you've done that validated patient feedback, so the bigger activity, you need to ensure that you share the outcomes of what that feedback told you with patients. Usually that's done through websites or signage in waiting rooms. And you need to outline what have you done in response to that feedback. So actually doing the surveys is one component, and the actioning of the feedback is the other. And it's the actioning where many practices kind of go, oh, I didn't kind of do too much with that other than read the report. And your surveyors may well ask you to come back with more of a response in terms of what you are doing or what you have done or what you're planning to do in response to your patient feedback. And you can see how that all sort of continues to weave into continuous quality improvement. Okay, we are now going to move into the last module, which is around the general practice module. There are 6 standards within that module. The first one is access to care. The second one, comprehensive care. The third one, qualifications of our clinical team. The fourth one, reducing the risk of infection, and we're going to do a little bit more of a deep dive into that one. Then the medical practice and vaccine potency, so, vaccination, cold chain management and the like. So there's a fair bit in the general practice module for you to get your head around as well. So in terms of reducing the risk of infection, this is a really key area of risk for medical practices. And so I've popped it in bold, make the text a little bit higher, make sure that you give this the attention that it deserves, because if you get this wrong, it can really have some dire consequences for your patients and for your practice team. So it's important. So the areas that this indicator or this standard looks at is around hand hygiene. How do you go about, informing patients of hand hygiene? How do your doctors and your clinical team work around hand hygiene? What's the training that they've received around that? How does it actually play out within your practice? Personal protective equipment. And I guess, most practices are pretty well versed with that now, having sort of come out of the COVID trauma over recent years, that, many practices have had such a lived experience of, dealing with pandemic, etc., that their capability in this area has really improved markedly, which, I guess is a good thing. And I guess I'm hoping that the learnings out of that haven't been forgotten, now that the acuity of COVID is kind of taking a little bit of a back step. Want you to make sure that you maintain your systems, your policies, your protocols around all of your infection prevention and management. So PPE, aseptic techniques, precaution levels and how you work around those. Staff immunisation and protection, and we've spoken about that a couple of times already as well. Managing of sharps and sharps injury and exposure. Cleaning, laundry and waste management. Instrument reprocessing, so, whether you're doing on-site sterilisation, autoclaving, or whether you're using, disposable instruments or the like. Disease surveillance, outbreak response, and there are also some planning and design considerations, which is really relevant if you are considering any sort of remodeling of your premises. You will want to make sure that you come back to this infection prevention and control guidelines book and have a look at the optimal design considerations from the viewpoint of infection prevention and control. If you have a practice and it is what it is, you need to think very carefully about how well it addresses the, I guess, the gold standards or the requirements of optimal infection prevention and design processes within your practice, and see whether perhaps, you know, workflows or smaller tweaks can help get better outcomes as far as that's concerned. So let me talk you through that a little bit more as well. So what we're talking about here is the RACGP Infection Prevention and Control Guidelines. There's a little image there on the slide as well of what the book looks like. All of this is available online as well. And it has recently had the update in June, so that's not that long ago. Like I said, if you are looking at any kind of remodeling, go and have a look at it, because it's going to give you some really good guidelines on what to consider when you're mapping out, especially your treatment room functions and, you know, your waste management and sterilization instrument processing areas as well. So let's talk a little bit about pre-cleaning of reusable instruments. There were some questions that had come up prior to today's session that kind of asked for some further clarity around what the requirements are. So we do know, and this is certainly stipulated in the Infection Prevention and Control Guidelines, ultrasonic washers, disinfectors are absolutely considered to be best practice for instrument cleaning. Not too many practices have got them yet. It's starting to happen, but these ultrasonic washers, they do have a cost associated with it. And at this point in time, they are not yet mandatory. So we're really in a state of flux there, where the recommendation is to use these instruments because, or these washers, because they do a much better job at pre-cleaning your instruments than manual techniques. But we won't, I guess, you know, penalise you from an accreditation point of view for not having that just yet. Mark my words, this is going to change over time. How long that's going to take, I'm not sure. That hasn't been determined. But over, I would imagine, the next year or years, this will switch from being not mandatory to becoming mandatory if your practice processes instruments on site. And of course, many of you don't do that. Many of you have disposable instruments. This does not apply in that scenario. If you are considering an ultrasonic washer and you're just kind of wondering, is that something that we should be looking at? Be aware that it requires its own performance monitoring and validation. So there's time, impact, and process involved in that. So think about the upfront cost, the cost to maintain the washer, and then the validation and monitoring costs that go along with that as well, to determine whether that's where you think is the right place to go for you as a practice. Again, I guess I would just come back to that notion of the intent of the standard. What that might mean is that for really large practices who are processing instruments on site, as a surveyor, I'd probably be leaning far more heavily on the requirement to use these sort of, you know, gold standard processes with the attached costs versus a really small practice that is reprocessing instruments. So I hope that gives just another example of the flexibility in which surveyors may assess the standards that are associated with this. If you are still undertaking manual processes, so manual cleaning of your reusable instruments, then you will require 2 sinks, and that is the distinction between what's called a dirty sink and a clean sink. So dirty instruments are the ones, as indicated, have not yet been cleaned, and it is in the dirty sink that the first cleaning will start to take place. And then the transferring of those pre-cleaned instruments into the clean sink for further washing and further processing. You are required to have a separate sink for hand washing. aside from the instrument cleaning sinks, or you need to have access to hands-free hand rub. So if you don't have enough space for, 3 sinks within your treatment room area or wherever that reprocessing is taking place, then you must have this alcohol-free and hands-free hand rub. Not alcohol-free, there's likely to be alcohol in your hand rubs. So the hand rub needs to be able to be accessed without using your hands. So it will be on a sensor basis whereby the hands don't touch anything whilst you're going about doing that hand cleansing. So again, I might just pause for a moment and check in with Elisa to see if there are any questions around that.
There's no questions in the chat box or Q&A function, but if we are coming to an end, so if you'd like to start putting in your questions, and then I'll ask shortly.
Okay, excellent. Thanks, Elisa. And so, look, just wrapping up my components, just be very clear that we've not covered everything. We've just taken a snapshot with a few ideas and things to be thinking of when you are contemplating your accreditation. My message to you is start preparing early. You do not want to start doing this 3 months before your survey visit is due. Your stress levels will rise if you've got so little time to do what is still quite a hefty amount of work. Share the workload with your team. So delegations are really important in this space. Accreditation is a whole of team activity. It is not a practice manager activity solely. So a lot of communication will be required to help you really sort of hum along with your accreditation there.
Just a quick question. How early in advance do you recommend starting to prepare for accreditation? Or did you say that?
Okay.
I missed.
Yeah, great question. I think it depends a little bit on how well prepared you are already at a point in time. So if your practice has undergone a number of accreditation cycles already and has performed reasonably well, then the changes from 3 years ago to now are reasonably modest, and your activities would be focused on ensuring that you still absolutely do what you say you do. Review your policies, procedures, update wherever it is required, crossing the T's and dotting the I's. So that's a lower, I guess, intense activity than if you are starting from scratch. If you've not done this before, I'd say give yourself 12 months, right? Start 12 months before your accreditation is due and give yourself plenty of time. I also highly recommend that if you are a newer practice manager or in a new practice, you've got to time block to allow yourself dedicated, uninterrupted time to work on these processes. You cannot do this accreditation preparation whilst you are also dealing with other issues. So telephone calls, especially if you are also providing support at reception, I'd be saying be really, really careful, because you cannot do this work and be constantly interrupted. There is a fair bit of sort of cognitive load involved in the thinking, the planning, the documentation, the checking, the auditing in all of these standards. So you've got to have dedicated time. I guess what I would recommend, if you're a new practice or a new practice manager, you might want to look at probably a 3 or 4 hour block per week as a minimum to start focusing on this. If you find that and you're really pushing through it really quickly, you can always pare back on it. But if you don't make that time available, I'm telling you, the stress levels will rise. So probably time blocking is another one of my key recommendations here. So yeah, again, how long is that piece of string? Think about how much work you still need to do in order to get yourself ready. So on the screen here, you will see the QR code and the URL up in that orange little section there. If you pop in there, you will get access to all of the resources that I've been talking about. So it's quick access to the standards, all of the resource guides, the security and general practice, we haven't even spoken about that. but the Strive for 5, which is about vaccine management, the business planning guide, the patient feedback guide. I've also popped in there the infection prevention and control standards. Frequently asked questions, that comes from the RACGP as well, and some other information, some practical tools. It's up to you whether that's of interest to you. So that's some resources that I've developed over a really long period of time to take a bit of the sting out. So that's a practice management and risk register.